These are our medical students. You're going to see a lot of them throughout the day. They're part of our, yay! All of them could not be here with you today. We always like to bring in students, and part of the Kids Alliance for Better Care is through the generosity of Children's Healthcare of Atlanta, and they know that there is such a need in rural communities. They have given 10 full ride scholarships for 10 pediatricians a year for 10 years. Isn't that great? In addition to that, they've given 10 scholarships for marriage and family therapists because they know there is such a need for them in rural communities. And so they've given scholarships for 10 of those for 10 years as well. And Sarah is one of our students in the back here, and there are others that you'll see through the day. So that's a wonderful thing, and they are required to go to a rural community for at least 4 years. But what we do is, much like Mercer, we only choose students who are from those communities anyway, because we know that 4% of medical students in the United States are from a rural community. So that tells you why a lot are not going to rural communities. They don't know them. They don't understand them. We know that there's a whole lot more. And there are people that are not from rural communities that are fantastic doctors in rural spaces all the time. We see it all the time. But we also know that there's a greater chance that they're going to go home or they're going to go to a rural community because they know it and they love it and they want that kind of life. And so that gives a great opportunity for medical students to return home and return to rural counties in Georgia. They must go in Georgia, to one of our 120 rural counties with no debt from medical school. So that's a tremendous blessing and boost for them. So we're grateful. Nathan Deal Scholarship is that for the School of Medicine, and then Children's Healthcare of Atlanta has made that possible for Mercer students. So if you see them throughout the day, not all of them are going to be pediatricians. Some are here and they're taking part in the OBGYN project this summer, the observership this summer. And so they're going to be OBGYNs in rural communities. And so we're grateful to have them here. So you guys pat them on the back and encourage them if you see them today.
Thank you. All right, so I'm going to introduce the next speaker. Maliha Haider-Bardill is a highly accomplished profession with a passionate dedication to improving the lives of individuals with autism, spectrum disorder, and development delays, particularly within the crisis intervention and special education. Her extensive career began in 2005 as a behavior therapist at the May Institution, providing home-based applied behavior analysis services and parent training before progressing to the role as a behavior specialist at Georgia Regional Hospital and a self-employed ABA therapist. She further honed her expertise as a special education in Fulton County schools, developing engaging lessons, implementing behavior intervention plans, and addressing diverse learning styles for students with special needs. After a career break for parental leave, Maliha returned to the workforce in 2023 to her current position as an autism project manager for the Georgia Department of Behavioral Health and Development Disabilities, overseeing crisis services for youth with ASD, educating law enforcement on proactive strategies, and spreading autism acceptance. With a Master of Education in multiple and severe disabilities with an autism spectrum disorder, specialization, a graduate certificate in public health, and a Bachelor of Arts in psychology, Maliha combines strong academic credentials with practical experience. She maintains an active leadership role in her community as a PTA president and Fulton County Commission on Disability Affairs board member, and a history of presenting on key topics like functional behavior assessment and the principles of ABA. Please welcome Maliha.
Hey everyone, it is nice to be here. Thank you all for coming out. I'm excited about this, and I want to kind of shout out to our last presenter. I also, and no matter how old the child is, I'm going to say there are some people at DBHDD that don't love when I say this, but I'm going to say it anyway. Get them on the planning list ASAP. As soon as all your paperwork is in order, get them on the planning list. Because, yeah, they might not be funded for 15 years, but they're there, we're aware of them, and the process is just that much more streamlined. Okay, so I'm going to talk about Georgia's Autism State Plan. There are a lot of misconceptions that hopefully this presentation will clear up. So ultimately, the state plan consists of 3 agencies: Department of Public Health, Department of Community Health, and the Department of Behavioral Health and Developmental Disabilities. I will do an overview of our sister agencies, DPH and DCH. And I can provide some, if you have deeper questions that I can't answer about what goes on in those sister agencies, then I can, gladly refer you to somebody who can answer those questions. But of course, my ultimate expertise is at DBHDD. So essentially, beginning in the state fiscal year 2018, the legislature aligned funds for services and supports for individuals with ASD that are under 21 years of age. The 3 state agencies: Public Health, Community Health, Behavioral Health, and Developmental Disabilities. So ultimately, Public Health, they were responsible for early identification and intervention services. Community Health is responsible for adaptive behavior, assessment, and treatment. And DBHDD is responsible for crisis support services for those individuals. So let me go over in a little bit more detail what the Department of Public Health's role in the Autism State Plan. I was sick, by the way, about 2 weeks ago, and I've got a lingering cough. So if I, start to sound like a frog or need to step away for a moment, just please excuse that. So the Autism Services Initiative serves youth from birth to 21. They wanted to improve assessment, and screening was one of their biggest initiatives, diagnosis, and then ultimately early intervention, and then transition planning out of those early intervention strategies. And those early intervention services, you probably all are fairly aware of Babies Can't Wait, and they started those in 2019. So they have developmental screenings that are typically provided by the primary care provider, the child's pediatrician. This is under the EPSDT, Early Periodic Diagnostic Treatment Services. Fairly sure that's what that stands for. So every well child visit, I have my kiddos are a little bit older, so I don't remember exactly the cadence before 1 year old, but there are several well check visits before the baby turns 1, and then gradually they turn into annual visits. So there's developmental monitoring at those visits, just kind of, chatting with the parent, seeing how development is going, if the baby's reaching their milestones. And they look at those for every well check up to 5 years. And then there are more formal diagnostic screenings. This is typically the MCHAT. And I don't remember what that stands for at the moment. But that is typically the screening tool that they use to see if, possibly more intervention is needed. And then they do. You're so sweet. Thank you. ASD specific screening, which is the MCHAT, at 18 months and then either 24 or 30 months. And if there's any sort of delay that's fall off, suspected at any of those intervals, then they would refer out to possibly a developmental pediatrician, somebody with more expertise for further evaluation. So their early intervention services are very individualized to the family, to the child. They understand that, family is their world, in terms of a child, they know that that's their main kind of the epicenter of their family. So they support families in their caregiving roles. They work towards collaboration with families. They don't ever want to do anything that kind of doesn't align with the values of a specific family. And then the services specific to ASD are administered by BCBAs or somebody, possibly an RBT that's supervised by a BCBA. And their services they provide a wide range of services. My youngest actually received speech therapy through Babies Can't Wait when he was young, and it was very helpful for him at the time. But they do evaluations, they do assessments, they can help with any sort of assistive technology. If a child needs an iPad or a speaking device to help them, they can provide behavioral intervention, obviously speech, vision, PT, OT, any kind of litany of any of these and probably more are available through DPH. And this is for the 5 and under age group. And then Babies Can't Wait, it's through 3 years specifically. And they start transitioning out of that program at as early as 27 months. But transition planning needs to start at least at 33 months. So they can make sure that there's a smooth transition out of Babies Can't Wait into some other appropriate services for that child, which may look like preschool, public or private. It could be the Head Start preschool, which will be a public one, private therapy, community groups, story hours, play groups, and things like that. To make the referral to receive services from DPH, their single point of entry is called Children First. And I don't know if you'll be receiving these slides, but that at the bottom is a link to that. And if you need help accessing that, talk to me later and I can help you with that. But it's just, I think it's a 1-page form. It's fairly dense, but it's a 1 to 2 page form. And it's typically done by referrals from the pediatrician. They're evaluated to determine if they need more evaluation or if the child can just directly access Babies Can't Wait services. So, and then we have the Department of Community Health. So after Department of Public Health, they age out of those services, the Department of Community Health can step in and provide the next level of support. And they do what they call adaptive behavior services, which we all know is ABA, or applied behavior analysis. So it's a treatment benefit for any person who receives Medicaid and who has an autism diagnosis and is under 21 years of age. They, in addition to ABA, just fairly recently, I think within the last year or so, Medicaid, DCH got further funding for behavioral aids in the home, which can just kind of provide some additional support to families that. Thank you.
We will.
I appreciate it. They just, for those kiddos that have, really challenging behaviors, and need some more constant level of support than ABA can provide. DCH at times is able to find behavioral aids that can step in. And as long as there is already an established ABA provider, they can access those services because the behavioral aid needs to be supervised by a BCBA. So all these services, they have to be medically necessary, and that's, that's determined by their physician or psychiatrist. ABA services can be accessed. They can be in-home, they can be in the clinic, they can be telehealth, which may work for some kiddos, or at least maybe some check-ins, but they're not limited to a certain setting. And really, the question that I get a lot, especially from our field office staffs, is how can a child access the autism state plan? And really all that entails is finding an ABA provider that is willing to serve that youth that accepts Medicaid. And then the ABA provider will then submit a prior authorization through, that also goes through Alliant. Most of this stuff goes through Alliant, just like Katie Beckett does. But that's really, it's that simple. You just need, well, if your child has very challenging behaviors, it's not that simple. If you live in a rural area where, you know, there aren't as many BCBAs, it's not that simple, but you just need to find a provider and they can take it from there in terms of filing through Medicaid. Department of Community Health also oversees our psychiatric residential treatment facilities, or PRTFs. And these are available for youth within the age range under 21 that have ASD along with ASD or IDD, along with the co-occurring behavioral health disorder. So if they have ASD and bipolar, or IDD and ADHD, but they do need to be dual diagnosed to access PRTF facilities. And these facilities provide intense out-of-home treatment for youth with very challenging behaviors. And the medical necessity criteria obviously still applies. There is a form that an MD needs to fill out. It's either the child's pediatrician, psychiatrist. If they're happen to be in an acute unit, like a crisis stabilization unit, sometimes those are handled, these referrals are handled by the CSU. But there's a form that the doctor needs to fill out and includes some supplementary documentation, psych evals, clinic notes, kind of just to make sure that this child really does meet that level of care that, an out-of-home placement would be better. Because obviously we want to go for the least restrictive environment, and that is always in home. But sometimes that's just not sufficient for some kiddos. And I'm not really going to talk about this much because you guys just got a great lesson on the Katie Beckett waiver. It's really not part of the state plan, but I did want to include Katie Beckett and GAP just because they are under the jurisdiction of DCH, and it's just another resource that, could be useful for families. GAP, as Ms. Dobbs mentioned, is available for medically fragile children. They need skilled nursing. They need very, specific personal care support. And these are some, that's also a link, but you can also take down those emails if that would be helpful if you have specific questions about the GAP waiver. This is just a handy little graphic I like. It was created by a colleague, Wendy Tigreen. It just kind of shows who is responsible for what, which is one of the, when navigating the system is one of the things that families, I think, have the most kind of tenuous grasp on because it's complex. This is not, an easy linear system. We all know that. The school system at this age, under 21, they are going to provide the primary supports. They should be providing the primary supports. And then outside of school hours, DCH can take over and, work with ABA. They can do behavioral aids and all those things. And then once the child ages out, is now an adult, more than likely ages out of those other systems, other departments, then they can be eligible ultimately for now comp funding. And yes, it's true. It is, minors can get waiver funded. It is very, very rare. It has to be a pretty significant need for an individual under 21 to receive now comp funding, but it does happen. It certainly does. And now to DBHDD. So this is my department. I work with the Office of Crisis and Transition Services at DBHDD, and I oversee crisis services for youth. And so these are essentially our four main categories. The first two, the mobile crisis system and intensive at home, are not specific to youth with ASD. They are, anybody with an IDD diagnosis is eligible for intensive at home. Anybody in crisis is eligible to, call 988. And then the 2 are specific to youth with ASD. So the mobile crisis system, just a very, very brief overview. 988 is an easy, handy number to remember. They've, in the past several years, they've really enhanced their team model of, they understand that ASD is a very prevalent issue. And they've hired BCBAs, they hire staff that, are experts in autism. And if a call comes in that, and the caller is made aware that this is the individual calling is autistic, or they're calling about an autistic child, they will send another, it'll be kind of a dual response. I just want to make a very quick note about language, because I think language is really, really important. You're going to see me waver back and forth between person with autism and autistic person. It's, person-centered or person first versus identity first language. I was taught in all of my education, person first all the time. With this neurodiversity movement, a lot of actually autistic people are saying, well, it's not a disability. It's who I am. I'm autistic. So if I don't know what a person wants to be referred as, I'll kind of, whatever comes out of my mouth will come out of my mouth. If I know for a fact that somebody wants to be referred to as a person with autism, that's what I'll call them. Just wanted to clear the air on that. All right, so intensive in-home. I'll just skip straight to the actual slides on these instead of the summary slide. So yes, 988, they will screen, they will access, they will respond. It's available 24 hours a day, 7 days a week. Yes, do you have a question?
Ms. Mahay, your slide 4. So you said that, okay, let's say working into a hospital setting. Okay, when we're intimating, when we're calling to get resources for a child or a person that has ASD, how do we in a hospital setting relate? Do we relate this as the same thing as saying that I have a person with autism and we're looking for a certain level of care, so that way they don't sit on the GCAB board for 24 to 48 hours? Because that's normally what happens with a child that has ASD. They sit on that GCAB board forever.
They can, that's true. You could reach out to me. I will have I think my email is on the sheet, and I'll have my phone number up there. So I'm going to get further into the ASD CSU a little bit later. But if a child is between 10 and 14, they are excellent at picking up those kids when necessary. The problem stands with older kiddos, especially that are on the more severe to profound edge of autism. Not a lot of CSUs in our state will accept those kiddos. So I understand that. And I'm also going to talk about the crisis homes, because that's an up and coming, another option. So let me circle back. And if you still have questions after I've gone through everything, then, feel free to raise your hand again or come find me after. Okay, so the mobile crisis services, again, in-field assessment, they can do telehealth visits. They can also come specifically out to the house. They will de-escalate. If they can de-escalate the crisis on the spot, they will do that. If they can't, they will make referrals out. They always leave recommendations at the very least for the family. And sometimes those referrals are for the mobile crisis team can refer to intensive at home. They can refer to intensive, what we call intensive out of home, which for these kiddos would be the crisis homes. So I work very closely a lot of times with mobile crisis. And we can, kind of, if they're not quite sure what might be appropriate for this child, we'll kind of, figure it out. We'll just kind of brainstorm and see what we can figure out that will help. So they will refer to those services, refer to community services as well. And they also follow up after the crisis to make sure that those referrals and recommendations have been followed up on and those linkages have been made. So intensive and home services. This is a crisis service through DBHDD. It is our lowest level of care in terms of crisis services because it allows the individual to stay in their community, in their home. Again, this is not limited to youth with ASD. Anybody with IDD, an IDD diagnosis can receive intensive in-home services. A lot of times those referrals do come through mobile crisis, and a lot of times people reach out directly to me. There's a form to fill out, like with everything. There's a pretty simple form to fill out, and then once I receive that form, I submit it to the provider. We have 4 providers that serve different regions throughout the state, and I make sure that that has been received. And then once the referral is received by the provider, they have 24 hours then to reach out to the family to get more information, find out what they need, and schedule their services. One of the misnomers about intensive in-home is it's not really designed to work directly with the individual. Intensive in-home is really designed to work with the caregiver and the family system. For the older population, we work with group homes, and, family homes, all the, wherever the individual is in the community. So if the individual has a current behavior plan from maybe an ABA provider, or if they have a crisis plan from a previous CSU stay, then the intensive in-home clinicians can kind of retrain or kind of build up the training for the support system so the family or the caregivers know how to implement those strategies that were listed on the behavior plan. And if they don't have an existing behavior plan, they can still train on behavioral interventions, what could be useful at what time to respond to what behavior. So there's a lot of training involved with intensive in-home. They can consult also with whatever services that the individual is currently receiving. So if they have an APB provider, they'll reach out to them and, say, what are you seeing? What are some barriers? What are some challenges? And that can help with the training as well. And then they can refer to community-based services if the child doesn't have an ABA provider, if the child doesn't have a psychiatrist, they can help to find those providers for them. They can also suggest kind of assess the environment for some modifications that might be necessary. So, if a child is an eloper, which is very, very common, as I'm sure we all know in this population, they can say, okay, well, this kind of lock works best in this kind of place, or, this kind of alarm would be best on this kind of window, just to kind of look around and see how we can make the family safer. And a lot of times if, the child is receiving family support services, like was talked about, or, they can apply for family support services, they can help fund a lot of those modifications, even a fence around the property, depending on the provider. So if that's something that is needed, then family support could ideally step in and take care of that for the family. All right. And then we have our crisis support homes. This is a relatively new program, which at the moment, I'm sad to say, is offline, but it is. So we had a provider, the provider backed out of their contract, and we have identified a new provider. They have found a house. They are currently renovating that house. It's located in Warner Robins, so not far from here. And at this point, it's projected to open in just, a few weeks. Knock on all the wood that, we know how dealing with contractors can be tough when renovations are involved, but hopefully that will happen. So this home is designed to serve kiddos 10 to 17 years old with an autism diagnosis. The program used to have 2 homes. When I first started, they both served 10 to 17. There were 3 beds each. One was in Kathleen, Georgia, and the other was in Jonesboro. After about maybe a year and a half of looking at the data, I'm a huge data nerd. I'm on the well, I don't have access to the GCAL board right now since Caroline took over, but once that's going to be remedied, typically I'm on the GCAL board every day, seeing who needs services, who's in the hospital, who can I help, essentially. So I take a lot of data on any kid with ASD that comes up on the bed board, which is now operated by Caroline. So looking at those data and those trends, I saw that the transition age, 18 to 21, there weren't many services out there for that age, and the need was very, very high. So, after some finagling and talking to higher ups, we got one of those homes transitioned to serve 18 to 21-year-olds. At this point, our plan was, when we were first developing this program with this new provider, which is Benchmark or operating as Enact, we were going to assign 18 to 21-year-olds to this first home that was opening, because again, the need was just higher in that age range. Now we have the CSDC open here in Macon, and there are also some additional crisis homes that have been open that serve individuals from 18 to 21. So they have more options now. So we're dropping that down to serve 10 to 17, because we want to make sure that even though the need isn't as high for this age range, it's still high, and they still need services. So we're going to be opening that ideally next month. So in this program, they have a team of a program manager, a BCBA RN, and a case manager. The program manager kind of oversees day-to-day operations. BCBA obviously, attends to the behaviors. RN can do any kind of medical, nurse, med administration and things like that. And the case manager primarily works with discharge planning, among other things, but that's one of their main focuses. And these homes are staffed 24/7. They always have at least one LPN and one RBT per child admitted at the time. It's designed to last about 30 days, but that's all based on how the child is progressing towards those behavioral goals. So when a child is admitted, the BCBA will take the first, usually about 7 days, for observation, data collection, treatment planning. So they will kind of define the target behaviors, do some functional assessments to kind of see, what might be motivating those behaviors, and then they create their behavior support plan. The BCBA then trains all the staff on the behavior plan, and they all implement it accordingly, and they have fidelity checks to make sure that all the staff members are implementing the behavior plan appropriately. One of the biggest components of this program is caregiver training. So we have weekly meetings that are virtual. The whole treatment team meets and talks about progress. We can talk about what, next steps might be if we're getting close to discharge, and what the family needs in terms of discharge planning. And before the child is actually ready for discharge, even if they've met their behavioral goals, the parents need to, or the caregivers need to show their proficiency in implementing the strategies written on the behavior plan. So it's an in-person training, and it kind of gradually fades out from the DSPs, the RBTs, doing the interventions, to the parents or the caregivers doing the interventions in the kind of safety of the crisis home. So once that they show that they can work these interventions, then the child will officially be ready for discharge, and can, go home with their parents. Of course, this is a voluntary program, so if at any reason parent wants to pull them out, they are able to do that. The reason that the caregiver training is such a crucial component is, the child can do all this great work in kind of finding appropriate strategies to deal with their emotions rather than, hitting, or whatever their inappropriate or their challenging behaviors were. But if they return home to the environment that they came from and nothing has changed besides what they've learned, they're going to revert back almost immediately a lot of times. So everybody that's involved with that child needs to know how to respond to certain behaviors, in order to kind of keep them, to keep everybody safe. Ultimately, that's the goal.
Okay, I have a question.
Yes.
Okay, so this plan that y'all have, the safety training for parents to come in, how could you recommend something like this to come into the school system in our special ed department, so that we can do not only just mindset training, but training that can help in additional setting that can help the school system be prosperous for parents?
That's a really good question. I have done some training. This is very specific. The behavior plans are obviously very individualized to the child or the adolescent. But I'm more than willing to come out and provide some training. I've done it for DFACs, law enforcement agencies. Just, reach out to me and we'll see what I can do. Yes.
As a spin-off of that, do you ever send anyone for that specific child back to the school for at least a transition meeting?
Yes. So thank you for bringing up the school part. So what typically happens when a child is enrolled in school, is they will be disenrolled from their home school and then re-enrolled in, this would be Houston County schools. So they would either, if they were able to go to school, physically go to school, then they will do that while they're in the crisis home. So, we don't want that gap in learning. And, even though it's a change in environment, it's still setting up similar routines. And then we always talk to the homeschool, the case manager connects with the homeschool. If they are willing, they are welcome to participate in our weekly meetings to keep them up to date. Anybody that's involved in this child's life, any other provider, ABA provider, school counselor, teacher, they're all welcome to attend our weekly meetings. And we do talk to them about discharge planning and what that's going to look like. Everybody that's in the orbit of that child ideally is involved in this program. So there are a few exclusionary criteria for this program. We can't do any sort of psychiatric stabilization. So if a child needs a change in medication, there's no MD or oversight for that. We can, obviously, if they take medication, they will continue to receive the same medication that they take with doctor's orders, but we can't change those medications. If they have any kind of, they would need medical clearance. So if there's any kind of overarching medical concern, if they have, a dental issue that's causing pain and probably therefore challenging behaviors, we're not a dental clinic. It just wouldn't be appropriate for us to serve that child until those medical issues are taken care of. And there's also an elopement assessment, which at this point is kind of up in the air is in terms of what that is going to look like. With the previous provider, it was a pretty strict assessment, and they were a little bit quick to want to deny a child because of elopement. But again, huge issue in this population. So we were constantly working with, even though they scored high risk in this assessment that was developed by the provider and it wasn't actually a validated tool, but that's, another concern that kind of irked me, but it's in the past. Then, we'd work to see what can we do to safely admit this child. Do they need extra staffing? Do they need a 2-to-1 to make sure that they're going to be safe? Do we need to, beef up the fence outside? Are there anything there's already the property is fully fenced. We need to kind of do another environmental sweep to make sure that, all the alarms are working. And, that's part of their annual certification checks anyway. But, if that is, say it's 6 months between certification checks, let's just double check those things one more time to make sure everybody's safe. Yeah.
So if the child's primary musical and program is elopement, what would be their alternative if you all don't accept?
Well, that's my point is I don't want to ever deny somebody simply based on elopement. And, the alternative could be any number of things depending on their age and needs. But yeah, what I'm really trying to say is I never wanted to just deny a child because they elope. Always wanted to find some way to accept them. And, going in with this new provider, they have not written that part of the policy yet. So I'm curious to see what that's going to look like. And if it's, as stringent as it was last time, then, we're just going to have some conversations because I don't want that to be a disqualifying criteria for anyone. So this isn't terribly relevant at the moment because this program, the 18 to 20-year-old home, isn't going to be operating for some time. But when it does come back online, they have to be pre-eligible for services. So they need to be on the planning list. We don't want somebody, a 20-year-old to be admitted and then essentially have nowhere to go after they've been stabilized. Because if they can't go back to their family home, which is the ideal, but I understand, especially for this older population, that's not always going to happen. Then we have our field office staff that can help support and find a more permanent, appropriate placement for that individual. All right, and now we have our ASD Crisis Stabilization Unit. It's located in Conyers. It's kind of referred to as the ranch because it's on a lot of land and it looks like a ranch. But it's a fantastic facility. I work with the staff. I talk to the director almost daily. She's wonderful. Their program just is incredible. They serve youth from 10 to 14. At this point, we are in talks with Viewpoint Health to increase that age range and possibly separate the existing unit. So half of the unit is 10 to 14, half the unit is 15 to 17. Because a lot of the individuals that couldn't have been served in the crisis homes because of some psychiatric presentations, they would be more appropriately served here at the CSU. Forgot to mention that at the crisis homes, if a child they need to have autism as their primary diagnosis, essentially. So even if they maybe have a schizophrenia diagnosis, that's not necessarily a disqualifying criteria. But if they are showing active symptoms of, psychosis, if they're having delusions, if they're hearing voices, that's, again, it's a behavioral program. Those kind of symptomologies, that's not treatable through behavioral means for the most part. So it just wouldn't be an appropriate placement for that child. The CSU, on the other hand, they provide some really intense behavioral services, but they also have a DBT component that works with the mental health side. They have worked with every child that comes through that program participates in DBT. Kids that are nonverbal, kids that are labeled as profoundly autistic. These clinicians are still able to modify the programming in a way that can reach those children. It's really beautiful, actually. So they, similar to the crisis home, they do all the needs assessments at the beginning. They look at their ADLs, their activities of daily living, what they need support with, what they can do independently. They do FBAs as well, and they provide some educational support. So these kiddos actually receive their schooling on the unit. They don't leave to go to school. They have a teacher employed that will teach them as part of their day on the unit. And they also provide caregiver training. It looks different than the crisis homes, just because our, licensing and certification, they're just different. It's harder for parents to come, caregivers to come, on a regular basis. And in the space that they have to provide the same kind of training, but they still have 7-day treatment teams, treatment planning, discharge planning, all of that stuff is still handled in the CSU. And they really do some phenomenal work. I'm really proud of that program. They're awesome. And
But hey, how many beds does the ranch hold?
it currently has 10 beds. The problem is it's never actually served 10 kids, partially because the way that it was designed didn't really, and this was years and years ago, before my time, before, a lot of my team was part of this program, it wasn't really designed with these kiddos in mind. The acuity of behavior, they didn't really understand what that would look like. So the main unit is just this giant room with a nurse's station in the middle. Ideally what we'd want to do is just divide the unit in half and then have, half, 10 to 14 and then, 5 beds on each side. They currently have staffing for, I believe, 5 maximum right now.
Also, I want to mention something, Ms. Hayes.
Yeah.
So you talk about mobile crisis, right? And we're talking about people that live in the rural areas. So with mobile crisis, sometimes mobile crisis is about 2.5 hours out for most people that live in rural areas.
Yeah.
When they come into the home and they get there and the situation has de-escalated, how do you still encourage the parent after realizing like they don't fought the war and then y'all doing the traveling trying to get to them, but the war over now? So how do y'all encourage parents to still want to call y'all to come out?
The documentation. I mean, they think that, and that's a really common concern. I've heard that a lot. He was fine, and I look at the referrals, and call was canceled because child fell asleep. After doing, whatever sort of damage to person or property before that. And as frustrating as it is, the mobile crisis responders can't respond to what they can't see. So they do need to come out. If it is truly a life-threatening emergency, I'm not saying don't ever call 911. Sometimes that is necessary. But I would say always 988 as a first resort. 911 should be the last. But I do know that there have been some life-threatening emergencies that, 911 needed to respond to, and the child needed to be taken by ambulance to an ER. But still, you just really need to say, the more times you call, we take data on everything. So if they're looking for, say, a PRTF, that documentation, if they want, if they feel a child needs a longer out-of-home stay for treatment, that documentation will really help to demonstrate medical necessity. Again, if nobody knows what's going on, then nobody can help.
I have a question. I saw on a couple of your crisis interaction team or resources that they talk about parent training. If I have a patient in my office whose parents need training, but they're not in crisis, if they have a child with autism, are there services available somewhere that we can refer them sort of ahead of the problem?
Sometimes I use intensive in-home for that purpose. It is technically a crisis service, but it is designed to basically head off a bigger crisis. So, you're more than welcome to get in touch with me in those circumstances, and we can see if intensive in-home can help. Yes.
Is there an age restriction on the intensive home care? Because I noticed for the other ones, it was 10 to 14. Is there age restriction on it?
Technically, yes, but so the minimum is age 4, and then 2 through the lifespan. Anybody above with IDD with above 4 years of age is eligible for intensive in-home services. Any other questions? It's my info up there. If you want to scan that QR code, all of that will just automatically get onto your phone. Feel free to email. If you call, leave a message, because if you don't leave a message, I'm not going to call you back. That's all. Thank you.